Good morning, everybody. I would like to thank Dr. Talal and Dr. Yasser for this excellent event. This is one of the first meetings about specialized in IBD, and it's my pleasure to be one of the presenters. So I would like to thank them for this opportunity to be here today. So what I'm going to talk about, optimizing biological therapy in IBD, like Dr. Talal put it, to the last drop. So I think that's what we have to do. So I'm trying to find a way to optimize our therapy for our patients as much as the options that we have here in Kuwait. Like we've heard from the previous speaker and excellent presentations about the future. So now I'm going to present what we have to deal with at this stage and the options that we have now. So as you know, the traditional approach for medical therapy in IBD consisted of a progressive escalation of medications as the disease progressed and the severity in order to induce clinical remission and maintenance. And with the advent of biological therapy and a greater understanding of the pathogenesis of the underlying inflammatory bowel disease, this treatment logarithm subsequently shifted toward a new goal of reversing macroscopic inflammation in order and modify the natural course of the disease by achieving mucosal healing. A growing body of evidence suggests that gastroenterologists should strive for mucosal healing in addition for clinical remission, because we used to look for the symptomatic approach, just to be happy if the patient is happy, and get rid of the steroid to make the patient happy. And that was our goals in the past, but that was not enough to change the course of the disease. So when we find that mucosal healing, that's the only objective that can change the course of the disease, because when you achieve mucosal healing, you will reduce hospitalization and surgery and also prevent the disability and the more complications. So this is a busy slide, but I want to concentrate in two things. So it's very important to understand where to intervene. Like some patient may present in early of their disease and some patient may present with late stages. So if the patient present at an early disease, looking for having mucosal healing, no biological inflammations, for example, the CRP and the fecal calprotectin is normal. Here, the outcome will be complete absence of symptoms, no disease progression, no complication, no disability, and no normal quality of life. And that would be applied the same to the patient who present late. Your aim would be mucosal healing, and by the mucosal healing we mean there's no ulcers and colonoscopy, and improvement or normalization of the CRP and fecal calprotectin. And the outcome will be the same: stabilization of non-inflammatory symptoms, no progression of disease, no damage, and no disability, and improve the quality of life. So this is the normal. Most of you are familiar with this approach. We used to be before and still being used, having the patient from mild to moderate and severe, and accordingly you would treat. It depends so the options that you have where you classify your patient. But I'm going to talk about how to apply this to your patients. So steroid is a good drug, but for the short term, because at the short term there's a complete remission of 58%, partial response 26%, only 16% they don't respond and they go for surgery or other alternative options for therapy now. But after 1 year, only 32% who maintain their response, but the rest will be switched to steroid dependent, or they may go for surgery. So at the short term, steroid is a good drug, but in the long term, it's not an option at all. And there's a clear evidence that the usage of steroid increased mortality in Crohn's disease patients. So we look for a new drug, a new medication, new hopes. So what we're looking for, the best drug, the drug that have a high efficacy with high safety profile. And when you look for any other of drugs, that what you're looking for is like to be in this corner, was very effective and very safe. When you look for the steroid, it's fairly effective, but the safety is a big question mark about it, especially on the long term. while when you use the anti-TNF, it's fairly effective, and the safety profile is excellent for the last, I think they start using anti-TNF since the year of 98, 97, and until now, the safety has been clarified and looks fairly a safe drug. But we know our disease severity is increasing, so we have to intervene at one stage to prevent the complication. So why we didn't reach that point yet, and how we can do that, and how we optimize our usage of therapies for IBD patients. You have to intervene in the right time. You don't want to be too early and too late. If you want to too early, you expose the patient for unnecessary risk of side effect of their medications. And if it's too late, then the medication will not be as effective as if you intervene earlier. Should be at the right dose, the right interval. So there's a clear evidence if you break through in between the infusions, for example, or the injection, that will affect your result and efficacy. It should be the right duration. The big question, when to stop, that's still a big question mark in the field of IBD therapy. It should be the right efficacy in a way with a good safety profile. And hopefully, if you have a cheap drug or with the right cost, that would be even better. So we know, like most of the patients that they were interviewing here, some of them are fairly mild disease. So with the mild disease patient, you would like to start with a step-up approach to avoid intensive therapy, immunosuppression, and adverse event. And then if you want to identify the patient who has aggressive disease, so then you have to go with the top-down approach. We're starting with a hit with the anti-TNF, and then you use the other medication. Here, assure early intensive therapy to avoid complications. The big question is how we could identify our patient. Where is my patient that I'm going to see now in the clinic? Is he having a mild disease, a moderate disease, or he may have aggressive chronic disease? So what we're looking for, are there any prognostic factor that could tell me who's the patient will have aggressive disease? There's a lot of prognostic factor you could use. The clinical prognostic, clinically, look at the patient disease, the behavior of the disease, if he's a smoker or no. The endoscopic picture, if the patient has mucosal healing or he didn't. Imaging, genetic, there's a specific genetic, like card 15 showed that these patients have aggressive disease. Serological marker like CRP, and also the fecal marker, which is fecal calprotectin. So we could use these prognostic factors to help us to identify where is our patient. So why we couldn't reach that? Why we couldn't identify a good prognostic factors? Because the existing classification system was fairly not homogeneous. There's a variation with the phenotype of the disease, changing of pattern over time of the same disease in one patient. And also because depends on subjective symptoms and treat the patient accordingly in a crisis management rather than a long-term management. And because the treatment were not working, but some patients have different mechanism, inter-patient variation, maybe a wrong dosing or lack of patient adherence. So when we modify these factors, we may improve our care to our patient. So this is a very interesting study where they done truly, when you look for the randomized control trials that being built up to usage of medication through the FDA or through the medical organization to agree, they take a specific group of patients in the inclusion criteria. But when you apply these medication in the clinical, in your clinic, that's completely different. In real life is a little bit different, specifically for Crohn's disease. So we look for this group of patients who been qualified in a randomized control trials. We saw the responder was about almost 89% or 90%. But when you look for the patient who's in the clinic, that's post-marketing study, where the patient who would not qualify to enroll in the randomized control trial, the response went from 89 to 60%. But this is less variant with the ulcerative colitis because I think more ulcerative colitis is more a homogeneous group, but with the Crohn's disease, there's a big variation of patient and also variation in the behavior of the disease. So when you look for randomized control trial, that doesn't mean you're going to have the same result in your patient. So that's why we have to look for, in the last 5 or 7 years, there was a medical term they used for time, and now they switch it, called tailored therapy. So you have to be like a tailor. The suit that fit you will not fit somebody else. So we have to individualize your therapy. And by individualizing your therapy, it depends on the behavior of your disease, in your symptoms, and if the response. So the benefit of individualized therapy will lead to a better characterization of the patient and their disease, directed therapies with the defined endpoints using pharmacokinetic guidance sometimes, objective endpoints of the disease control and monitoring, specifically looking for targeting for mucosal healing, and also monitoring for any disease drift, because patient may switch from one type of Crohn's to another type of Crohn's. So among all this noise, all these populations that you see in the background of the picture, you have to look for individualized therapy. So you have just to look for your patients, and then you try to help him as much as you can. So you have to understand who's your patient, select the most adapted individualized therapy approach, and empower your patient by education. So when you ask who's your patient, there's a different factors, but the most important one would be age, ethnicity, and the disease history. And when you look for the age, it's clear that in the pediatric population of Crohn's disease, the patient start with inflammatory type, and then only small percentage start with the structuring, and very small 4% with the penetrating. But with the time, this is like until 5 years, but after 15 to 20 years, you will see most of the patients who are inflammatory, easy to treat, that less side effect and complication with a better prognosis, will switch to structuring or penetrating disease, which is difficult, more advanced disease that may lead to disabling and exposure to surgery. When you look for the elderly population above the age of 40, most of the patient will maintain with the same behavior of the disease, that they, a very small percentage may switch to penetrating or structuring disease. So, but it's obvious if you have a patient who's young age, that's clearly is that having a poor prognostic factor. And that's why you have to intervene earlier to avoid the long-term disability and complication. The same will be applied for ulcerative colitis. When you look for the age population, for example here, after 5 years of median follow-up, in the pediatric population, 49% of the patient will have a disease extension, while in the elderly population, only 16% of the patient will have a disease extension. So age is a very important factor, and you have to understand that with your patients. We know that the disease, I'm sure most of you are familiar with the slides, most of our disease is having flare and remissions. So the more flare you have, the more difficult it's gonna be, and the chance of having complications getting higher. So if you catch your patient here at the diagnosis, you have to be clear that you have to deal with the disease and as much as you can to avoid any further flares, because if he develops flares, he may develop strictures, fistula, and abscess, then that will lead to surgery and another disability. And if the patient continue not controlled even after the first surgery, he may expose to another surgery and more complications. So we understand who's our patient first, what could be the prognostic factor we could use, then we look for now individualized therapy. So what's the options for individualized therapy? You have to look for the severity of the disease, the response to therapy, and the risk of therapy. But prediction is very difficult. It's not an easy job, especially if it's in the future. We don't know. We have few tools that could help us what's the behavior of the disease, but there's nothing to assure us 100% that that's what we're dealing with. So because the picture may change in the future. So when you look for there's a lot of predictive factors that to tell you that the behavior of the disease is fairly aggressive. So like the locations and the colonic involvements, the anal adhesions, age below 40, smoking, deep ulcers, and few genetic factors. But the most important to me is disease location, the extension, and the lesion depth. The same would be applied for ulcerative colitis. There's extension, the colitis extensiveness, if the patient associated UC with the sclerosing cholangitis. But the most important with the UC is disease extension, age of onset, incomplete response to 5-ASA and the steroid. That's fairly a poor prognostic factor. So when you look for response to therapy, the predictor of response to therapy depends on the age, body weight, smoking. The albumin reflects the nutritional status of the patient. It's then the severity of the disease. The CRP also one of the biological tools. So here when we noticed, like in this slide, for the patient who has been given anti-TNF like certolizumab Bigol, if they give it to early in their disease, like below 1 year of the diagnosis, the response almost 68%. But if you intervene like later at 5 years after the diagnosis, drop from 68 to 44%. So you have to know when to intervene, and you don't want to be too late, because too late will give you a poor response. And as I said, you don't want to be too early to avoid the complication. But by having all these tools about prognostic factor, individualized therapy, understand who's your patient, all these factors will help you to decide when to start. And it's always better to start early rather than late. And this is the same applied for the patient who's been taking adalimumab and infliximab in Crohn's population. So with the blue box, like patient who has early anti-TNF introduction, and with the time you see there's very few patients who had case-related Crohn's disease-related surgery. So from 4, 6, 7, and 9. But when you have the patient who has immunosuppression first and then anti-TNF, so there was a delay like 336 days, then you see the risk is getting higher. And the same applied for the step-up approach, so the chance of having surgery related to Crohn's disease is getting higher. So if you start anti-TNF early, that will modify the course of the disease and decrease the risk of surgery and hospitalization. The same applied with the UC. Maybe you saw one slide from the previous speaker, I think, about the patient who has been naive to anti-TNF have a better result compared to the patient who has experience with the anti-TNF before. So when you look for the clinical remission, there's a better improvement also with the clinical response by the CDAI, I think more than 100 points. Also has a better response in the patient who's been naive to anti-TNF. And we know that the patient who has exposure to TNF, you think that he has a more complicated disease. That's why he's been exposed to more than one TNF agent. So what's the risk of therapies you have to look for? Always patient concerned about complication, and that was one of the most important part when I came, like 2003, when I came back to Kuwait, and always the patient think that this medication looks biological therapy, it may kill me and all these things. So we had a lot of difficulty at that time. But now we know that we have a good safety profile for this medication, but there could be increasing risk of serious infection with the anti-TNF, like older age, comorbidity, longer-standing disease, severe disease, including surgery, malnutrition, leukopenia, concomitant use of steroid, and frequent hospitalization. So when you have these factors, you have to be cautious with using the anti-TNF with your patients. So how we could empower our patient and how we improve their adhesion to therapy, their knowledge about their disease. So this study, they found that a patient who they just advised them to follow a website and to register on a website, and fairly a simple study, and they found that with the time the adherence to treatment was increased from 30 to 40%, but just by advising a patient have a website. And we know now most of the advanced centers in IBD, they have programs for their patient education. Also, they have an IBD nurse who's dealing with all the questions of their IBD patients, and also if there's any complications that could be available. And they have, like, some centers, they may have a hotline for phone contact all the time. So now what do we do next? So if we have these options and we know where to interfere, and then our patients, we know who has a poor prognostic factor and who's a good prognostic factors. If we decide to go with individualized therapy and start the treatment, how we monitor the patient. So we have to have a frequent monitoring, disease monitoring and assessment of response to therapy. So you don't just give the medication, tell them, okay, I'm gonna see you in 2 months, and that's it. So you have to assess and monitor your patient closely, looking for their disease and the response to therapy. So what we're going to do is review the evidence for use of surrogate markers and which marker correlate with remission and mucosal healing, and how often to monitor, and are there any evidence to monitor, to use these factors for monitoring post-op patient. And then that we go to treat to target, and then we'll talk about therapeutic drug monitoring. So when you have just following your patient, asking just for the symptoms is not enough anymore. So monitoring by symptoms is completely out of the logarithm now, because there is no correlation between the symptoms and the endoscopic finding and the disease course. The overall accuracy of clinical response, clinical symptoms improvement is to endoscopic inflammation is only 56%. So as you flip a coin, if the patient is going to improve or no, you don't know if he told you that my symptoms is gone, but endoscopically 50% he may not have an improvement or mucosal response. Do we need new biomarkers? And we have to define what's a good biomarkers in IBD. We have to find the marker should be a marker of the disease activity, predict the imminent relapse, predict the post-operative recurrence, predict the response to therapy, and assist in treatment optimization. So if you find this marker, that will be very helpful to monitor your patient by using these markers. So the good markers should be accessible, easy to process, reproducible, easy to interpret, and hopefully to be cheap. So, and at the end, what we're looking for is a meaningful answer to the biological questions, like if the patient have active disease or no. So the biomarkers, there was a many biomarkers that been studied. The most and the important one is the C-reactive protein. The other were not a very good biomarker to depend on. And for the fecal markers, fecal calprotectin was the best options for a biological marker that you could use. So these two markers, C-reactive protein and fecal calprotectin, are very important and being used nowadays in the outpatients clinic for monitoring the patient response to therapy and assess their disease. So regarding the CRP, it's an accurate marker for disease activity in Crohn's disease. It correlates with the clinical endoscopic severity, equally well for small and large bowel. 25% of the patient, they may not have a C-reactive protein response. And when you use it for ulcerative colitis, is less valid, but a normal CRP, most of the patients, 75% of the UC population, they may have a normal CRP despite an active disease, sometimes used in severe colitis. But you don't depend on a one reading of CRP. Previous CRP in a given patient more informative than one absolute value, because patient who always has CRP response look versus a patient who never had a response to a CRP. So when you do frequent CRPs, that will guide you monitoring your patients. So a good prognostic characteristic for using the CRP is increased level predict response to an early normalization, and early normalization predict the sustained response to anti-TNF in Crohn's disease more than UC. Increased CRP during follow-up of treatment, that indicate that there's a need for therapy optimization. So what exactly the role of CRP? As I said, CRP useful for monitoring symptomatic and asymptomatic patient. It may provide an objective measure inflammation of treatment decision and change or optimize your therapy. It may help to determine the need for endoscopy. If you have a patient who has a normal CRP all the time and out of a sudden his CRP is increasing, then the second visit The patient is symptomatically stable, but his CRP is increasing, then here you should think about doing endoscopy because there's evidence of inflammation by using the CRP. Recommended monitoring schedule for a patient with the Crohn's disease. So at baseline, all the patients should have CRP. And in asymptomatic patient, regular interval every 4 months is acceptable. In symptomatic patient, receiving induction therapy and those with fistulizing disease, doing the test every 4 weeks is recommended. So if you have a patient who has severe disease, then every 4 weeks. If the patient has stable, has no symptoms and no complications, then every 4 months will do. And there are a few data to support CRP monitoring in post-operative patients, but not highly justified. So we know that in this study that the CRP predict the disease complication. So when you have a CRP less than 1.4, you are less likely to go for CD-related hospitalization. But if the CRP is more than 1.4, your chance is almost 20% of the patient went down. So there's 3.4 fold greater chance of having admission to hospital related to Crohn's if you have a high CRP. So this is one of the tools that help us to understand how good, like easy, simple test like CRP can give you a big decision about your patient care. The fecal marker, also another tools or biological tools that you could use. It's a marker of the intestinal inflammation. It's not specific for inflammatory bowel disease. There's no clear superiority to one marker, although calprotectin was most validated in the studies. In Crohn's disease, it was a good correlation with endoscopic activity and mainly indicate for patient looking when you have somebody has a high fecal calprotectin, that tell you that this patient may need to do endoscopy to look for assess their disease. For a patient can be used for follow-up therapy effect if the patient has been treated and you don't want to repeat the endoscopy or colonoscopy, and the patient will hate to repeat the colonoscopy very frequently, so you could use fecal calprotectin as a follow-up for them. And it also can be used as a prediction of relapse. The value is basically patient with the normal has CRP. As I told you, there's percentage of patient with a normal CRP. So for these patients, fecal calprotectin has a big advantage in guide you and help you with monitoring your patients. In ulcerative colitis, there is a good correlation with endoscopic activity in general and clinical symptoms, and the indication mainly for follow-up therapy and prediction of relapse is the same. So when you look for fecal calprotectin, for the patient who has, it's not working. When you look for the patient who has like low fecal calprotectin, UC patient has low fecal calprotectin, and which is the purple one. Most of them has been symptom-free and without relapses. And the patient who had UC patient who had more than 50, then they did much better. And the same applied for the Crohn's disease, like with the green, but most of the patients has been without, a small percentage of patients went without relapses. And so that would help you to understand that if you have a patient who had a high calprotectin, that their chance of having symptoms and relapses is much higher. But the problem is that we have to identify what's the threshold. It depends on the threshold of fecal calprotectin you're going to use. So as I said, fecal calprotectin correlated well with the endoscopic lesions, and the sensitivity is about 70 to 100% with a specificity for 40 to 100%. Depends on the threshold you use, if you use a 50 or 100. In Kuwait here, for screening, they use different threshold, like if you have below 200, that's negative, above, I think above 500, because they don't have it in the government, it's mainly in the private, that's indicated with the equivocal between 200 to 500. But I think that will be completely different to threshold for the patient with inflammatory bowel disease. Also, it's a very good test for prediction of relapse with the specificity, sensitivity ranging from 40 to 90 and specificity to 40 to 88. Also, it depends on the threshold that you use between 130 to 400. Also, it has a good response to good correlation with the response to treatment, and it's very practical to use. It's sort of easy, but the only issue is that you have to use a small amount of feces to do the test. And there's now few tests that they give it to the patient, they can do it at home. So when you have this, in this study, they try to look for the patient who had the relapser and non-relapser. When you see the non-relapser with the yellow color graph, like the CRP is fairly stable here, but with a patient who had relapses, then the CRP is increasing, reflecting that the patient has active disease and predict the chance of relapses. The same applied with the calprotectin. The patient who has a non-relapser, they have a maintained same level of fecal calprotectin, but the patient who's relapses, they have a high level of fecal calprotectin. So these two tests could be used as tools for us for monitoring the patient, assess their response, and the need for doing colonoscopies. So when you look for the threshold here, for example, the patient who has a recurrence disease, they have, like in general average, a very high fecal calprotectin, but the patient who's in remission, in general, they have a low level of fecal calprotectin, reflecting that fecal calprotectin can predict relapse in patient with inflammatory bowel disease. So that's why they use could be the efficient marker to predict endoscopic remission. So a level of 100 mic per gram is a suitable threshold to select patients who require colonoscopic assessment. And when you have a patient who had fecal calprotectin less than 100, has a high negative predictive value, and we know that your patient is stable and he doesn't need anything. So, as we said, we do all these tests looking for mucosal healing, and the most important part is mucosal healing. So mucosal healing is an achievable, monitorable goal associated with better outcomes. It requires early introduction of effective therapy in a high-risk patients. And when you reach mucosal healing, you know that it's associated with lower relapses, lower hospitalization, and reduced need for surgery, predict the post-operative clinical recurrence, and also predict the relapse after anti-TNF withdrawal, and mucosal healing associated with lower risk of colorectal cancer and new ulcerative colitis. So what we have, we look for our target. So our target would be mucosal healing. So what we are trying to hear, when you assess the patient, you diagnose him, then you have to follow him and do your best to achieve mucosal healing, and that will take time, but it's different. So when you reach your target points by achieving mucosal healing, then you will avoid a long-term bowel damage and subsequent disability and complication. So is this achievable? We'll see. So when we say mucosal healing, because it's very important, because associated with altered natural history of disease in Crohn's patient and population, especially with reduced the risk of hospitalization and surgery. It's defined by that mucosal healing assessed by doing ileocolonoscopy, partial or complete, that depends by looking for there's deep remission or a few ulcers. Should assess that usually every 6 months until the ulcer disappears. So when you treat the patient, you have to do colonoscopy after 6 months to assess mucosal healing. If the ulcer disappears well and good, then you have to follow him every 1 to 2 years. But if the ulcer didn't help, you have to optimize your therapy and do the colonoscopy after another 6 months. And of course, as I said, we use the biomarker for follow-up, like C-reactive protein and fecal calprotectin. Use images whenever it's needed, like with the MRI, enterography, looking for assessment, further assessment of the small bowel. So here, our target to have, when you have an active disease, you treat. So after 6 months, you would like your target looking for mucosal healing and also have no symptoms. When you reach mucosal healing, most of the patient will have no symptoms and the CRP and fecal markers will be normalized. So if the patient achieve this, then we'll be happy just to continue doing colonoscopy every 1 to 2 years. But if we didn't, then you have to optimize your therapy and maybe by using combination or monotherapy accordingly. But the most important, not what type of medication you use as much as you achieve your mucosal healing. So treatment optimization during target-based therapy is very important. And by using the anti-TNF antibodies and the tough level, I don't want to spend too much time, but tough level is one of the tools that you could use, especially with a patient who has been exposed for your medication for long duration and he start to lose response. Then you could do different options if you have a low tough level. So you want to optimize the tough level, which is the level of the medication in the blood, by reducing the duration or by increasing the dose. And by treatment, drug monotherapy is very important and the new standard of care for, that's what I'm saying, it will answer many questions that it will help you to managing and achieving mucosal healing. So this is just a simple graph. I don't want to make the issues complicated. So the patient who has anti-drug antibody positive, they have a low bioavailability of the medication. So here you have to intervene by increasing the dose, by doubling the dose, or by decreasing the duration. So in summary, biomarkers like fecal, including fecal calprotectin and CRP allow us to assess response to therapy and may support effective treat-to-target approach by monitoring, by predicting imminent relapse, predict post-operative recurrence, and optimization of therapy. And as I said, therapeutic drug monitoring may help understand interpatient treatment exposure variability to establish the most effective dosing and duration, and to support also, as I mentioned, individualized endpoints. And treat-to-target approach based on regular assessment of disease activity using objective clinical and biological outcome and adjustment of treatment. We know we have to treat our patients because we want to avoid mortality. We know from this slide that that's a fairly big study that been done in Denmark showed that the patients who the patient who had Crohn's disease, they have a higher mortality compared to the normal population, and the mortality increase was most pronounced in women below age of 50 at the diagnosis. And excess mortality arose almost exclusively for complications to severe Crohn's and gastrointestinal cancer. This is just like a quick slide for looking for the patient who has been taking biological therapy. Adalimumab have a less related hospitalization related to Crohn's disease. So when you have this graph, like this is the natural history, we try to reduce complication, we reduce progression, and we would like to reverse the damage if possible. So can the treatment of natural history change? Yes, partially until now. By induce and maintain gastrointestinal healing, prevent structures penetrating complications, prevent the extraintestinal complication, decrease hospitalization, and decrease the long-term cost of care. And I know we've seen this before, but I think it's the time to change. So you have to understand where's your patient. You have to individualize therapy to your patients. It doesn't matter which approach you're going to use, but that depends on your patient and your understanding of his disease and what's the predictors of that. So as I said, when you have introduction of early combined immunosuppression versus conventional therapy, we have better evidence for having early aggressive therapy, always the gain bar higher, much higher than the conventional therapy, and also in the long term with a complete endoscopic remission was much higher with the patient who received anti-TNF early. So we know that having anti-TNF intervene early will have a long-term result and improvement. So In conclusion, we have a conventional step care, and that the conventional therapy has not changed the course of the disease and the natural history of the disease. It's highly effective therapies of these diseases are now available by using the biological therapy. Consistent evidence from randomized control trials showed that TNF blocker can reduce rate of surgery and hospitalization with acceptable risk of adverse event. This strategy is less likely to be most effective when implemented early in the course of the disease in a high-risk patient, and the emerging of concept to treat target has potential to relapse existing treatment logarithm. Thank you very much.